Okay, welcome everyone to the second installment of the BOMS Monthly Journal Club, which is part of the BOMS Webinars educational series. We're running these clubs on the second Wednesday of every month at 8 p.m. and we'll be rotating the presentations around the various UK bariatric units around the country to showcase the different units and the different team members. Now, the webinar this evening, along with the others, is recorded live and will be made and a recording will be made available on the BOMS website. I'd like to start off by giving you two important dates for your diaries. The first is the last Wednesday of the month, Wednesday, the 24th of February, 8 p.m. We have the renowned world expert Carl Leroux talking us about obesity drugs, okay, and how they can be used within the surgical service. And then 2 Wednesdays later, on Wednesday, the 10th of March, that will be the third BOMS Journal Club, 8 p.m. again, and the Bristol team will be leading that. So thank you to all the contributors. Now, the format, as with the first Journal Club, will be presenting two papers of importance to the MDT. The first paper will be presented by an IHP member of the MDT, 20-minute paper, 14-minute presentation and 6 for questions. Please post your questions using the Q&A function at the bottom of your Zoom. And the second paper will be a surgical paper, again, 20 minutes. Now, tonight's Journal Club is supported once again by Novo Nordisk. So they provided sponsorship to the BOMS CIO to fund the development and the promotion of this journal club, but they had no input whatsoever into the content or the agenda for this meeting. Now, I'm going to hand over to Chetan Palmer from the Whittington team. He will chair the rest of the club, and I will come back right at the end just to close the meeting. So thank you very much for joining us and enjoy the club. Chetan.
Thank you very much. Thank you, Sharif, for this excellent initiative. I think it's a good platform for doctors, AHPs, trainees, even medical students, I think, and probably, hopefully, for future, for the patients as well, to get some background of what actually happens. And without wasting time, I would like to introduce my first team of speakers. So first, it will be a joint presentation. First is Cleverly Fong. She's one of our dietitian who is with our Whittington team for a long time now. And the next is Katrina Burton. She is another bariatric dietitian who has joined our team recently, and they are our pillars of the Whittington bariatric team, if I can say so. Over to you, Cleverly and Katrina.
Can everyone see it? Thank you. So thank you to the sponsors and oopsie. And good evening. Thank you for the opportunity to give this talk. My name is Katrina Burton. I'm one of the bariatric dietitians at North London Obesity Centre, and I'll be presenting today with Cleverly Fong. Thank you for the opportunity to cover this very topical paper. We decided to cover a paper from the Netherlands on the topic of B12, namely the efficacy of oral compared to intramuscular B12 supplementation after Runway gastric bypass, a randomized control trial. You can find it in the June 2018 issue of the American Journal of Clinical Nutrition. Now, you might think that this paper is old, but I found it extremely topical, especially now since the outbreak of COVID-19, when patients report that it's been really hard to schedule appointments with their GPs for the injections. So a little background on B12 then. So B12 deficiency has been associated with macrocytic anemia, neurological complications, and neuropsychiatric illness. After Roux-en-Y gastric bypass, the lack of gastric acid and intrinsic factor limit the ability of B12 being cleaved from the dietary protein and later absorbed. Now, you need acid to denature the protein to make the B12 available, and you need intrinsic factor to produce, that's produced by the parietal cells in the stomach to couple and facilitate the absorption. Sorry. So the parietal cells still produce the intrinsic factor, but unfortunately now it's going to be produced in the gastric remnant after surgery, and so it's not available in the same way for the absorption. So the gold standard for the treatment of B12 deficiency has been intramuscular injection, but could oral B12 supplementation effectively increase the B12 concentration in a more comfortable and cost-effective way? So this was a prospective investigation, and what the authors are trying to answer is whether serum B12 concentrations can be raised and normalized in a deficient individual as effectively via the oral route as via the intramuscular route. So, So the study involved 50 participants selected from routine follow-up appointments who were found to be deficient. As we already said, it's a prospective randomized control trial. The participants were randomized using block randomization in blocks of 10. And the control group consisted of the usual treatment for this center, which is the intramuscular injection, and the experimental group received an oral B12 supplement. This study had two different types of outcomes. The primary outcomes would have been the serum B12, and the secondary outcomes were methylmalonic acid, MMA, and homocysteine. The length of the trial was 6 months, and now at the bottom it says attrition, 2 people. And now it wasn't attrition in the true sense. These people still ended up finishing the trial, but they misbehaved a little bit on the way. So one of them had to be eventually started on the intramuscular injection because they forgot to take the supplement as ordered. The second one, after the first 2 months, started taking their supplements, but still worth talking about those. Next slide. So why is it that we are mentioning, why is it that that methylmalonic acid and homocysteine were looked at all? Well, that is because, just a little reminder, serum B12 is maintained at the expense of the tissue status. So an individual could be B12 deficient, but have normal, regular serum B12 status. This is why methylmalonic acid is a better marker, because it reflects the functional status of B12. Cobalamin is a cofactor in the reaction when MMA is being converted to succinyl-CoA on its way to the citric acid cycle. If there is an insufficient available cobalamin, MMA will increase. And the similar idea behind the methionine homocysteine cycle, where again, the cobalamin is a cofactor. The only problem with these two markers is that they can be increased in other conditions. And so it does require somebody who understands how these markers work to assess. So this is just a really nice little summary of the inclusion and exclusion criteria. As I said, MMA and homocysteine can increase in different conditions, and I think that's what the exclusion criteria then tries to account for, just so that we're only looking at the gastric bypass patients here, not patients with other conditions. Next slide. So then who are the participants? So as I said, they were recruited from routine visits. If they had a B12 status of less than 200, the control group received a bi-monthly 1000 microgram hydroxycobalamin injection with the initial 2000 microgram loading dose. The experimental group received a daily 1000 microgram methylcobalamin. The investigators and the assessors were not blinded to the study, and the outcomes, as I said, were the serum B12, that's the primary marker here, and then we have the homocysteine and methylcobalamin. The serum B12 was assessed bi-monthly, so at the outset, 2 months, 4 months, 6 months, and the other two markers were assessed at the beginning and at the conclusion of the trial. The compliance was monitored by a research physician. So now this trial is based on the assumption that in the control group, 100% of the participants will have improvement, and the experimental group will have a 90% of improvement. To be sufficiently powered, this assumption needed to have 25 participants in both groups. The outcomes, as I earlier mentioned, were measured bi-monthly in the serum B12, and at the beginning and the conclusion in the homocysteine and methylmalonic acid group. So now this is the baseline characteristics. Really the only data of interest here is that in the BMI was slightly higher in the experimental group, but everything else seemed to be have no significance. So now I will hand you over to Cleverly, and she will discuss the results and the discussion portion of the presentation.
Okay, so I'll take you through the results. So this is a table to show the number and percentage of patients with their value normalized after 6 months. So there were 26 patients who had the serum B12 level measured in the IM B12 group, and 100% of them achieved normalization. For the oral B12 group, 23 patients had the serum B12 measured and also had 100% normalization. There were no significant difference in serum B12 between the IM B12 group and the oral B12 group. A total of 27 patients were included in the IM B12 group, and 100% of them had the MMA normalized. In the oral B12 group, 22 patients had the MMA completed, and of which 96% achieved the normalized level. Now, with a p-value of 0.46, the difference is insignificant, and the differences are within the group. There were 25 patients who had their homocysteine completed at 6 months in the IM B12 group, and 96% of them had achieved the normalized homocysteine at 6 months. In the oral B12 group, 20 patients completed a homocysteine measurement, and 87% of them achieved normalized homocysteine group with a p-value of 0.33, which again, the difference is also insignificant. Next slide, please. Now, when you're looking at these graphs, the gray squares represents the IM B12 group, and the black dots represents the oral B12 group. The top graph demonstrates the median value of the serum B12 concentration with the range throughout the study in both groups. There was a significant difference within each group 2 months after the supplementation, and after 6 months of the treatment, all of the 26 patients had their normal B12 concentration. The middle graph demonstrates the median value of the MMA concentration with the range at baseline and after 6 months of the treatment. And the white triangles represents the total number of patients with raised MMA at baseline and at 6 months. So the mean MMA concentration was significantly decreased after 6 months within each group, and MMA was normalized in all of the group of patients in the IM B12 group and in 96% of patients in the oral B12 group. The bottom graph demonstrates the median value of the homocysteine concentration with the range at baseline and after 6 months. The white triangle represents the total number of patients with raised homocysteine concentration at baseline and at 6 months. Homocysteine concentration decreased significantly in both groups, and after 6 months, the homocysteine was normalized in 96% of patients in the IM B12 group and in 87% of patients in the oral B12 group. And there was no significant difference in the change from baseline to 6 months between the groups. Next slide, please. Now, in the author's discussion, this RCT wasn't compared to a placebo group and not blinded. The design of the study was based on 2 formulations between the intervention arms. So there was the firstly oral against the IM routes, as well as hydroxycobalamin against the methylcobalamin. The other thing is, the patients are not really low in B12. So not in the sense of symptoms perspective, not even all of them had high MMA level at start. And in the discussion part, they did mention that if the patients were very low in B12, then they would have gone down to routes of IM routes anyway. Also, there were no consensus in the field on the best way to diagnose B12 deficiency according to this paper. Next slide, please. So missing participants from the analysis. So there were 2 patients actually taking the supplements wrongly or inappropriately. So that actually led us to think, did they actually have enough power at the end? Because if not, then the results are inconclusive, secondary to the low power. If you're looking at the BMI of these patients in the article, they were actually fairly low at around 30s. So we were just wondering, does it actually make any difference if the patients were actually having higher BMI? Also, would the oral B12 work in the same way in, say, for example, participants in older age, or for example, ethnicity is different? The study also wasn't very clear about how they've taken things into account, like, for example, the renal disease can actually elevate the MMA and the homocysteine using metformin or PPI, which are very common in our population. Next slide, please. So the trial, according to the author, has no significant difference between the two methods of B12 delivery at 6 months. From the point of view, giving the options to the patients with IM injection or oral B12 will actually help them to improve their self-efficacy. But they did observe that it may decrease the compliance if the patients were choosing the oral route. And certainly it was much harder in the study for them to monitor the compliance then. Now, at this point, will this paper actually influence your practice? Next slide, please. Now, just sharing a bit of our past experience from Whittington. So back in January 2019, one of our ex-dietitian colleague, Olivia Edwards, actually presented this in BOMS. So our take on it was, are we over-supplementing on B12? Next slide, please. So we looked at the serum B12 level in a small cohort of people, around 94 of them, across different surgeries, including sleeves, bypasses, minis. And we found that all types of surgeries actually had high serum B12 level, like with the 3 monthly B12 injections following the BOMS guideline. We also found it was actually much cheaper to ask the GPs to prescribe the IM B12 injections. And if you're looking at the differences in price, IM B12 injections about £190 without taking into account of the nursing administration time, of course, against the oral supplements somewhere between £14 to about £17, not 70. We also found there were more affordable oral B12 from over the counter anyway. So we found things as cheap as 4 or 5p for that 1,000 microgram per day that we need over 3 months. Next slide, please. Now, the recommendations that we made from our previous finding was perhaps we should look at whether we want to lengthen the B12 injections from 3 monthly to perhaps 4 to 6 monthly, and perhaps persuade the patients to look into purchasing their own high-dose B12 oral supplements. Fortunately, it looks like in our center, it happened already because of no choice. Given the pandemic, we already had to advise the patients and the GPs to actually look into the options of getting the oral B12 supplementation if IM injection isn't available. Next slide, please. So going back to what Kat was saying before, we have received a number of calls coming from anxious patients about, oh, I'm not able to get any GP appointments to get my IM injections done because of the practices were closed, for example, throughout the COVID period. This paper actually helped us to reduce the anxiety for the patients, to let them know that, look, it is about the same if you have the oral B12 compared to your IM B12, and it is safe to actually do that during the pandemic. Next slide, please. Now, question to the floor is, how comfortable are we as a group in keeping patients on oral B12 in the longer term, or for how long? And that's the end of the presentation.
Thank you very much, Cleverly and Katrina. That was a fantastic presentation. We've got lots of questions coming in. Shall we go right ahead? Mr. Palmer, do you have any that you wanted to propose, or should we go straight in?
I think excellent presentation, I would say, very relevant. And I can see loads of questions that it's just piling up. So let's crack on with the questions. I think we have limited minutes to answer those questions.
Perfect. So the first question we have is from Marcus Reddy, who says, do you screen for H pylori in patients with low B12?
Mr. Reddy, it's a pleasure to see you here. as you can imagine, not in the NHS, but the good thing is we are one of those few units in UK who screen or who perform endoscopy in all our patients preoperatively. And at that time, we do H pylori for all our patients and eradicate their H pylori before proceeding to any bariatric surgery. But to answer to your question, no, when I think for a low vitamin B12 in specific, no, because as cleverly pointed out, I think a B12 injection costs less than £2, whereas arranging an OGD and all, I think, I don't know how much it is helpful in changing the management plan.
Okay, so the next question we have is from Richard Thompson. He says, do you think the results could also be applicable to sleeve and Oagb patients?
That's a very relevant question, and it becomes relevant because if you look at the, I should say these are tough questions, Roxana. You are my friend. You should screen those questions. So these are tough ones. So if you look at the nutritional guidelines paper by Mary O'Kane, and I think she's probably beyond because I could see her somewhere. So I think if you look at the paper, the BOMS guidelines from last year, we did agree that yes, Oagb, Roux-en-Y, there is a bit of technical and limb length difference, but I think the consensus still is that unless we have more data available, and I think there needs to be a bit of uniformity, and ultimately we have to win the compliance of the patient as well. So if we start giving them different messages, it becomes more confusing. So I think easier is stick to one regime, and I think whatever evidence we have, I think it proves that it should be fine.
Thank you.
I think also in the short term, in the short term, while we have the pandemic on, I think it's a good guidance just to say, yes, take the oral supplement, because that 1000 microgram a day is a huge dose. The recommendation is 1.5 micrograms a day. And we know that the absorption of vitamin B12, independent of that intrinsic factor complex, just gets absorbed passively. So we could still be fairly confident that they'll probably get enough for the time being. And also B12 gets stored in your liver for 3 to 5 years. So if you have a previously well-nourished person, they perhaps won't become deficient overnight.
Agree.
Okay, so next question we have is from Ahmed. Do a couple of questions. Would you recommend active B12 or B12 serum levels to check for deficiency in B12? And secondly, is there enough B12 in Centrum 50 or Forceval to help the post-bariatric patients, or do they all need an additional supplementation?
Cleverly, Katrina, before
I think Forceval has about 1.5 micrograms, which would be okay for you and I who have an intact stomach and digestive system, but it might not be the same for, as I just explained earlier, if you get that mega dose and you absorb 1% passively, then that's not going to be enough, the whatever is in the supplement.
Agree. And I think if you look at all the evidence, I think there are about 15, 20 articles, and there's a systematic review out there as well. If you look at all that, 15 or 35 micrograms does not really help. There is an incremental increase in the B12 level as you start supplementing higher dose. And I think when you reach around 650, it is sufficient in post-bypass patients. And I think that is why these authors have not mentioned in their methodology why they have selected 1000. But I think if you look at the evidence, that's why they came up with that 1000 number, because the systematic reviews and literature shows that 1000 is good. And actually at 1000 dose, you sometimes do over supplement, as you can see from our previous poster, but I think it is safer at 1000.
Okay,
and one question. Can also add, sorry, just to answer some of the questions. Can I also add? So with the like whether we wanted to use B12, serum B12 as a test itself, or do we wanted to use active B12 as well? I think it's all down to the cost as well. So if you're thinking about the serum B12, the test, I'm guessing is probably around £5-ish. And when you're adding other things in there, and if you're thinking about screening for the whole population, it's going to be a lot more. So unless the person is actually, you suspect is symptomatic and you need to do that, I think the serum B12 is probably going to be sensitive enough to actually screen for deficiency already anyway. So practical reasons, just the serum B12.
And then we have one last, just a quick question to fit in. Should we be measuring methylmalonic acid, MMA, routinely in patients rather than B12 levels? I'm not aware that this is routinely available and it's very costly. Comes Mark in the trial.
No, I don't think so. I think MMA is very expensive. So I'm not entirely sure about exact cost, but I'm guessing it will be somewhere between £50 to about £100 per test. So if you're testing it out for all of the patients, again, it's not practical for the cost reasons.
Okay, I think because of time limits, we should probably move on.
Yeah, good, thank you. I think there are lots of questions. I will try to answer a few while we are proceeding. But yeah, let's proceed to the next presentation. And for our next presentation, we have, Katrina and Cleverly were the pillars of the Whittington Bariatric team. Now we have Naveed, you already have seen Roxana there. These people are the backbone of the Whittington Bariatric team. Naveed is our senior registrars, budding bariatric surgeon, and all over to Naveed.
All right, thank you very much, Mr. Palmer. Let me just start this presentation. Okay. All right, great. Good evening. Thank you all for dialing in. Thank you for BOMS for organizing this journal club. And thank you very much to Mr. Palmer for nominating me for this. My name is Naveed Hussain. I'm a surgical trainee in bariatrics at Whittington Health. I'll be presenting the following paper, laparoscopic Runway gastric bypass versus laparoscopic sleeve gastrectomy, 5-year outcomes of merged data from 2 randomized clinical trials, sleeve pass and SM BOSS, which are Finnish and Swiss trials published very recently. Now, the article was published in the BJS, impact factor 5.676 in 2019, and it is one which is free to access. The authorship is of Finnish and Swiss researchers who conducted the original trials. The paper mentions various grants and industry support given and some of the contributors' industry affiliations. They mention that the sponsors had no influence on the study, data analysis, or manuscript preparation. Now, laparoscopic sleeve gastrectomy is the most common bariatric procedure worldwide, overtaking Runway gastric bypass sometime after 2013. The 2 trials, sleeve pass and SM BOSS, both reported in 2018 their 5-year data, and both compared weight loss and other parameters following sleeve gastrectomy and Runway gastric bypass. And the authors state that neither study demonstrated statistically significant difference in weight loss between the 2 techniques, and therefore the aim of this study was to increase statistical precision by merging the 5-year data from sleeve pass and SM BOSS. Now, going through the PICO model, the population in the study includes all those captured in the original studies on which it is based. These are both very similar in terms of age and BMI criteria, with length of conservative treatment being 2 years in SM BOSS compared to 1 year for sleeve pass. Exclusion criteria in the original trials here have some similarities in terms of previous surgery, GORD, and hiatus hernia. However, they are not exactly the same. The intervention in comparison, as mentioned, is sleeve versus bypass. And primary outcome is weight loss as defined by percentage excess BMI loss, with percentage total weight loss as a secondary outcome. Other secondary outcomes are changes in glycemic control and effect of duration of preoperative type 2 diabetes on glycemic control, dyslipidemia, effect on OSA, number of complications, and effect of complications as assessed using CCI, which stands for Comprehensive Complication Index and is based on the Clavian-Dindo classification, and also quality of life. So is this research question relevant? So though there is already much literature available on sleeve gastrectomy and Roux-en-Y gastric bypass, there is still a need for robust and contemporaneous data on these operations. They are the most commonly used bariatric procedures worldwide, and the findings may inform decision-making regarding choice of operation. Now, the methods clearly state aims as well as primary and secondary endpoints, but this doesn't just include weight loss and resolution of comorbidities, but it also includes morbidity and quality of life. One question I had as a non-statistician was, why would merging of the two trials data, which they say separately found no significant difference between the two operations, result in any different result? The basis of this study, as mentioned, are the SleepPass and SMBOSS trials. They've been performed separately and are prospective multi-center RCTs. They're both registered trials and seem to be well conducted and reported appropriately. Now, the initial work in this study was to perform a statistical analysis of the variables between the trials, which found some heterogeneity, which I will come to later on. And following on from this, a mixed model analysis was performed, which is described in detail. The effect of each operation, interestingly, was assumed to be similar in both trials. For the main analysis, the intention to treat method was used, and the study says that a separate per protocol analysis was also used for some data. In terms of methodology, as I mentioned, the original trials seem to be well conducted. In terms of their randomization technique, SMBOSS used block randomization, whereas SleepPass used a sealed envelopes shuffling technique, which seems slightly less robust as a method. However, this would still minimize selection bias. In addition, both trials were not blinded. The reason given in SMBOSS was that specific complications arise from Roux-en-Y gastric bypass compared to laparoscopic sleeve gastrectomy, and therefore it is important for both patient and clinician to know which procedure is being used. However, this may have introduced some element of observer bias. Finally, the effect of each operation was deemed to be equivalent in each trial. However, in the original papers, mesenteric defects were not routinely closed in SleepPass, but they were closed in SMBOSS. The original studies had clear inclusion and exclusion criteria, and this was not altered at all by the new analysis. Now, in this paper's analysis of merged data, they state that it would improve generalizability of results, which I broadly agree with, and the statistical methods seem appropriate, in particular the mixed model technique, which can take into account variability of results at several levels and also for missing or unbalanced data. Appropriate distribution models were described for primary and secondary outcomes with logarithmic conversion used for some variables, for example, glycemic control, in order to carry out the analysis. The intention to treat method was used, which ensures groups remain the same regardless of the way participants progress on the trial or if they drop out, and would minimize attrition bias. However, it is not clear why the per protocol method was being described, and it doesn't also make it completely clear when this is used. The data from SleepPass showed that 80.4% of the original cohort was included in the 5-year analysis, while the number for SMBOSS was much higher at 94.5%. The merged data included equal numbers of sleeve gastrectomy and laparoscopic Roux-en-Y gastric bypass, although with slightly higher proportion from SMBOSS, even though this trial originally recruited fewer patients than SleepPass. The baseline data analysis found some difference in variables between trials, in particular for mean age and mean baseline BMI. They also found that in SleepPass, more patients had hypertension and type 2 diabetes and longer pre-op duration of type 2 diabetes, while the prevalence of dyslipidemia and obstructive sleep apnea was lower in SleepPass. For the primary outcome, percentage excess BMI loss at 5 years was significantly higher in Roux-en-Y gastric bypass at 62.7% at 5 years, compared to sleeve, which was 55.5%, and this difference remained significant between 1 and 5 years. The percentage total weight loss similarly was significantly greater in Roux-en-Y gastric bypass at 5 years. there is quite a large overlap in terms of range of values, and you can see that some patients actually gained weight by 5 years, although weight gain was not separately quantified. In both measures, the greatest weight loss was seen at 1 year post-op, with the percentage of both excess BMI and total weight loss decreasing over time. These are the results from the main text in the article, as I just have been through. For remission of hypertension and dyslipidemia, the study found statistical significance between bypass and sleeve, favoring bypass for both. For type 2 diabetes, both groups demonstrated significant improvement in both measures of blood glucose. However, there was no difference between the two operation groups. Interestingly, they found that longer duration of type 2 diabetes resulted in a lower remission rate. Similarly, for OSA and quality of life, their data did not show superiority of either operation. In terms of complications overall, the study data favored sleeve gastrectomy as having fewer complications. However, the calculated CCI score, the overall burden of complication, was not significantly different. In their table 2, the authors give the model-based results comparing each variable and significance of time and operation of choice. The actual figures here differ slightly from the main text, which I assume is because these values have been adjusted for random effects using the statistical model. However, the findings are the same. So overall, there is a large amount of data. However, P numbers are given and calculated, especially for the effective operation and the effect of time. I think the data is reasonably long-term and therefore makes it more reliable. The main text, however, does not make it clear enough what methodology was used to calculate the results given, while the table 2 does. The original studies, SMBOSS and SleevePass, were both powered greater than 90% and recruited the required patients. However, SleevePass accounted and allowed, should I say, for a 10% dropout rate. And at 5 years actually had a 19.6% dropout rate. This therefore makes their results at 5 years potentially underpowered, or at least less powered than they intended, which may affect the ability of that trial to reject the null hypothesis. It's also worth mentioning that the power calculation only here relates to the primary endpoint, which is weight loss. In terms of conclusions, the study reports superiority of renal gastric bypass in terms of weight loss, remission of hypertension, and dyslipidemia. However, it shows no difference between bypass and sleeve in terms of remission of diabetes and improvement in quality of life and OSA, while sleeve seems to have a lower overall complication rate. However, it does not differ in terms of the overall burden of complication as assessed by CCI. For the purposes of the primary endpoint, I believe this current data adds to the generalizability of the studies. In my opinion, the strengths of the study include clear methods in the original studies, which are good quality and with large numbers and a long follow-up time. Statistical methods are clearly described to account for variance in the data sets. It also mentions quality of life, which I believe is important and is not always reported in all studies. In terms of weaknesses, it seems that SleevePass could possibly be underpowered, as mentioned before. The study assumed no difference arising from the surgical technique. However, SMBOSS routinely closed mesenteric defects in real-wide gastric bypass and reported 9 internal hernias in their data, while SleevePass did not close mesenteric defects and reported 17 internal hernias with similar overall numbers of patients. This could potentially have some impact on the complication rate. Finally, the results are slightly unclear whether they were reporting an intention to treat or per protocol analysis in the main results. So will this change my practice? I think this study will inform my practice and will certainly be useful in the decision-making process, particularly in the MDT setting when deciding between bypass or sleeve, depending on the patient's priorities. Overall, this is a good paper and it adds to the body of evidence for laparoscopic room-wide gastric bypass and sleeve gastrectomy. It also agrees with established literature broadly in terms of weight loss and long-term results, although appropriately powered studies for other variables such as type 2 diabetes would be more useful. Thank you very much.
Thank you, Navid. Excellent talk. And I think it was excellent in a way that these are two complex RCTs, as we all know, the SM BOSS and sleeve pass. And I think it was a good summary of that, both RCTs here. Now, a quick question, how, I think you did mention it helps you in there, but do you want to stress a bit how can these study findings help you counsel patients who are actually struggling to choose between a sleeve and a Roux-en-Y gastric bypass?
I think simply some patients have different priorities. In particular, some people would say, I want the most weight loss I possibly can. And you could counsel them saying, Roux-en-Y gastric bypass will give you the best result long-term in terms of weight loss. Now, if they're presenting for bariatric surgery in favor of losing or gaining remission, should I say, of diabetes type 2, then you could say that either is an appropriate operation. And if they're wary of complications, or if they're worried about things like internal hernia, then you could advise them to have a sleeve. So it doesn't completely inform the MDT, because there are other variables as well. For example, things like history of eating disorder, which might influence your decision to favor one operation over the other.
Okay, we have a couple more questions coming in. Just in relation to that, does the small extra weight loss of 4 kilograms justify promoting gastric bypass over the sleeve? They've commented here that, in their opinion, both are equivalent for a daily practice for weight loss perspective.
Oh, is that a question to me?
Yes.
Yes. Is it a clinically relevant amount of weight loss? I suppose you could probably say it's not completely relevant clinically, and you'd have to counsel the patient to that. So I think it's shown really by the IFSO data that really sleeve is favored over bypass, and it's probably for that reason that it doesn't give you a huge amount of extra weight loss compared to bypass, and it's technically, some might say easier as an operation.
So next question we have is from Harvinder Jahal. Do we know why the data for type 2 diabetes remission is different to other RCT studies, in particular STAMPEDE? Could it be due to the fact that baseline glucose control was very well controlled prior to surgery, so any glucose effect may be difficult to see? Was the duration of diabetes not a short enough duration to see an effect?
I might ask Mr. Palmer about that, because he seems to have a bit more knowledge on all the RCTs.
I think, again, good question, whoever asked that. I think it's tricky here. I think we still do not know much about the diabetic remission here. If you look at, yes, these two RCTs, and I would say there are a lot of other RCTs as well, which have shown that that the diabetic remission in Roux-en-Ys and sleeves are same. But I think what is important here in convincing your patient, coming back to counseling the patient, is that this is a lot better in a long term compared to a medical therapy in long term, as had STAMPEDE or a Phil Shar's study shown. So I think that is probably more relevant. Here there is a bit of a difference. Probably, I don't know how the statisticians, because if you look at the sleeve pass and the SM BOSS, the initial BMI, and that is a bit different as well. And I don't know whether that has a role to play. But to be honest, I think we still need more studies. If you look at the systematic reviews of only RCTs, so forget all evidence show that the diabetic control in or weight loss is same in Roux-en-Y's and sleeves. But I think when it comes to systematic reviews of only RCTs, then Roux-en-Y, I think, trumps them. But that's only RCTs, so it's a bit tricky.
Thank you. We have plenty more questions, but unfortunately, I think we're running out of time. I'm sure we can try to get through and answer most of them in when the video is up on the website, for example, to look onto the BOMS website and in our social media chats. So I'd like to hand over to Sheriff Howard to conclude the evening. Thank you.
So just a few final words, just to thank Team Whittington for a fantastic, really, really informative discussion tonight. So Chetan, Roxana, Cleverly, Katrina, and Naveed, thank you all very much for your efforts. Next webinar will be the Wednesday, the 24th at 8 p.m, Carl LaRue. And then following that, the Bristol team will present on the 10th of March on the second Wednesday. But thank you very, very much, team, and to all the attendees.